I'm Verna, and I've been asked to speak to you about life from a carer's perspective, and in particular about what it's like to look after someone who's had a tracheostomy fitted. You're all health professionals, so I'm not going to try and tell you how to suck eggs. But unless you've done it, the role of a carer in the community is a completely different concept. Never has the saying of, you have to walk a mile in someone else's shoes to understand how it is, been more true. Not only are you dealing with medical problems, you are factoring in the added responsibility of caring for someone you love and the emotional involvement that brings. I'm not seeking for sympathy. I took on the role I had willingly and gladly. I just want to explain how it was. Bear in mind, unlike caring as a professional, for myself, there was no end of shift or run of shifts. No time to be ill yourself, no opportunity to take a day off or go away spontaneously. You were always on call, and the buck always stopped with you. I'd like to talk about a lot of things, but in the short time I have available, it won't be possible to go into great detail. However, I would like to give you a short potted history and flavour of daily life for a patient and close relative carer. To do this, I've prepared some notes to keep me on track, as what I will talk about covers several years of caring condensed into a nutshell. To give you a bit of background, my relative was my brother, Philip, who has now sadly passed away. Philip had Down syndrome, was living with me as he had done for many years, and enjoying a happy and fulfilled life in his own little way. He had his own interests, likes and dislikes, things he liked to watch on TV, favourite foods. He loved music, and like many people with Downs, totally convinced he had a singing voice. Philip had his own friendship group as he attended a day centre, travelling there by ledger bus or taxi, and he enjoyed going away in our motorhome. Sadly, all of that changed when at the age of 58, he suffered a stroke. Philip gradually developed swallowing difficulties, subsequently resulting in repeated chest infections and aspiration pneumonias. To cut a long story short, after a couple of years, Philip was fitted with a peg feed. Matters improved, and this worked successfully from a feeding point of view. And Philip and I enjoyed a relatively good lifestyle for quite a long time. However, he began developing chest infections associated with aspiration again. At a loss, I took him to be seen at the Royal Brompton Hospital in London, where, among other treatment, the consultant recommended a jejunostomy feed, which, as you know, is fitted into the jejunum and therefore less likely to cause reflux and aspiration. Philip still got chest infections, however, and after one nearly fatal episode as an inpatient with pneumonia, the physiotherapist and consultant suggested a tracheostomy be fitted to facilitate suction, as it was suspected Philip was still aspirating on his own secretions. It was an instant success, and from a permanently gurgly throat and silent aspiration leading to sudden severe breathless episodes, his breathing was quiet and easy. Every case is different, of course, but I would urge you not to always think of tracheostomies as a decline or further complication for a patient, because it can lead to an improved quality of life. In all, this involved a 3-month stay in hospital. Care for my brother fell into 2 broad categories: care whilst in hospital and care at home in the community. Both had their drawbacks and rewards. To speak about hospital care first. Being in hospital as a carer is an unnatural experience, I found. Without wanting to sound critical or ungrateful, because I'm not, I never had any doubts at all that all the staff really cared. My concern was there never seemed to be enough of you. In hospital, I went from being the person in total charge of looking after my brother at home, feeding him, keeping him clean, administering medication and nebulizers, doing wound care, preventing pressure sores, to, as soon as we entered hospital, any skills or experience I had built up seemed lost, and we were at the mercy of rigid protocols, where the dividing line between what I could do and could not do was blurred, to say the least, and varied from ward to ward and hospital to hospital. An example being, since Philip was such a high risk of aspiration, even after his tracheostomy, my mission in life became to maintain his position in bed at a 45-degree angle. This was fine whilst I was around to keep an eye on him during washing, pad changes, pressure relief turns and repositioning, but I encountered quite a bit of resistance to the protocol that to do most of these tasks you lie the patient flat, and there was reluctance to consider any other way of doing them, even though it could prove to have serious consequences for Philip. I felt very responsible for my brother. I knew him inside out, and I knew he was sometimes very scared on his own. I was reluctant to leave him at night because even after a 14-hour day, going home felt like abandoning him. I knew staff cared, but I also knew they got busy, and to assume that because he was quiet meant he was okay was not always the case. The hospital did come into its own, though, as before any discharge could be contemplated, I had to be taught a new set of skills around tracheostomy care. Importantly, knowing when to suction and how to do it safely and effectively became important. For as you all know, there is a definite method to doing suction cleanly and properly. I was patiently taught these procedures and supported by nurses and physios until we were both happy I could do them safely. The mixed blessings of hospital became a comfort, knowing that whilst there, professionals are on hand. Getting a doctor's opinion, a blood test done, a chest x-ray, or a course of antibiotics when Philip needed them were relatively easy. Again, missing out quite a lot of detail, but preceded by quite a lot of equipment arriving at home. For example, hospital-style profiling bed and air mattress, a wheelchair, a hoist and slings, a special chair to sit in, suction machine, catheters, dressings, no end of medication, plus all the enteral feeding equipment and consumables. The day of discharge arrived, and the little fan club Philip had built up, who used to compete for one of his smiles, waved us goodbye, and we were off home. It was such a pleasure to be home, for us both, after so long in hospital, to relax in our own surroundings and enjoy a more normal life. Although weak at first, Philip's chest was so much better. He enjoyed a far better quality of life as I was able to remove excess secretions for him. He was discharged in the May, and we used the summer to get out and about a bit. Getting out was quite a logistical task, however. To take him out for either a walk in the wheelchair or further afield in the specially adapted car, which took the wheelchair with him in it to the seaside or wherever, I needed first of all to hoist him into the wheelchair, take the enteral feed still running in its battery in a rucksack. I was always petrified that the line was going to get caught up in the wheels. The suction machine, catheters, gloves, spare inner and spare trachea kit in case the worst happened, gloves, dressings, sterile water, brush, any meds that were due whilst we were out, syringes, and later, after an assessment at Papworth Hospital, where central sleep apnea following the stroke was diagnosed, some low-flow oxygen, all of which came with us. It always amused me that the formal procedure of suctioning, as done in a hospital setting, had to be performed in the real world now. And I had to do this as cleanly as possible for Philip in many a situation. For example, laybys on the A1, the seafront at Cleethorpes, and walking around Rother Valley, to name but a few. So you can always reassure your patients that having a trachea doesn't have to stop them doing things they enjoy. This level of support came at a personal cost, however, as for the first nearly 8 months after coming home, I was on duty 24 hours a day and never had more than 3.5 hours sleep at a time, as there was no one to take over at night. It is, as you appreciate, not possible to anticipate when someone needs to be suctioned, and Philip had no way of alerting me other than me hearing the familiar gurgle sound. After 8 months, to avoid burnout, I applied for help and was eventually allocated an allowance for a carer to come 2 nights a week, and I did the other 5. As Philip became more ill, it progressed to 4 nights and finally the full 7. I could bore you to death with carer stories, but fortunately for you, there isn't time. For some years, caring for Philip was a way of life. And in addition to the personal care, giving feed and fluid, medications, nebulizers, changing dressings, cleaning jobs and routine appointments, there was also the admin and equipment to take care of. Things like cleaning the suction machine, replacing the filter and pressure testing it, same for the nebulizer, checking stock and ordering enough feed and consumables from Nutricia, getting suction catheters and gloves from the district nurses, trachea consumables, checking medication and ordering it from the doctors, collecting it from the chemist, continence supplies and portable oxygen cylinders from Baywater, to name but a few. Any wobbles that Philip threw in along the way, which were many and varied, also had to be dealt with, but again, we haven't time for them today. Being a carer in the community means you have to be resourceful, because to all intents and purposes, you're on your own. And I built up quite a directory of useful numbers for when I needed advice or help. Inexplicably, though, most of these people didn't seem to know each other. There was the GP, a lovely man who'd known Philip for over 30 years, and who knew if I rang, it wasn't for something trivial. Community respiratory nurse, community dietitian, district nurses, continence nurses, occupational therapists, not forgetting Sister Lucy Brooks, who came monthly to change the trachea itself. All these people were a great support, but, unlike hospital, not available 24 hours a day, and had a heavy caseload. So it could take many telephone calls and a whole day to get hold of who you wanted, by which time I'd often had to make a judgment call myself. It also seemed sod's law that whenever Philip had a crisis, it was the middle of the night, a weekend, or a bank holiday, or all 3, and sometimes it just had to be an ambulance. Fast forwarding a lot, as Philip became more and more unwell towards the end of his life, there was a big responsibility to decide at home on my own what was necessary to keep him safe and comfortable on a daily basis. This included deciding whether to start the course of antibiotics I always had. Obviously, it wasn't wise to give them unnecessarily, but to leave him once he'd begun an infection led to severe breathless episodes. Deciding if the diuretic was not enough or too much. Deciding the dosage and frequency of powerful sedative drugs. That was the downside of being in the community on your own, outside the safety net of a hospital. I believe I got it as right as anyone could because of how well I could read Philip. I would not have had it any other way, and I don't regret it. I'm grateful for the extra time we had together, bought in large part by the tracheostomy. Thank you for listening, and it's worth saying to you all that you're all important. The experience of how you deal with your patient, and definitely for their nearest and dearest, stays with them for the rest of their life.
Thanks, Verna.